Like the hardship in climbing to the peak of mountain, this video presents a series of procedures performed to maintain the eyesight in a young patient. A 25-year-old male presented with dimness of vision for last 5 years. He was diagnosed with healed viral keratitis leading to leukomatous corneal opacity at visual axis with one quadrant deep vascularization. The patient was taken up for standard full thickness keratoplasty under local anesthesia. All precautions were taken to have a good graft host apposition and thus minimal astigmatism. Post-operative period was uneventful. The patient was very happy to gain vision of 20/20. To manage astigmatism and provide better quality of vision, I went ahead with topo-guided selective suture removal after 9 months of primary surgery. Subsequently, patient was happy to continue his daily activities and follow up with me regularly. One sudden day, the patient had a fall from bike that led to injury to the operated eye like sudden avalanche in mountain. On examination, he had vision of finger count with spontaneous extrusion of crystalline lens and vitreous loss along with graft dehiscence of approximately 180 degree. The patient was taken up for graft dehiscence repair under general anesthesia. I tried to save the prolapsed iris by repositioning it into anterior chamber followed by suturing of the graft. Residual cortex was removed with vitrectomy probe. Triamcinolone was used to facilitate anterior vitrectomy. The graft was sutured properly to the host. Anterior vitrectomy was completed. Anterior chamber was formed with balanced salt solution. Post-operatively, the graft survived and best corrected vision was 20/20. Optical coherence tomography excluded subclinical cystoid macular edema. I was encouraged to take the patient for secondary multipiece IOL implantation with inferior haptic fixation to the sclera. Hoffman's reverse pocket was made followed by limited anterior vitrectomy. Chondroitin sulfate dispersive viscoelastic was used to protect corneal endothelium. Railroad technique was used to pass the Prolin suture tied with inferior haptic. Superior haptic was rested on residual rim of fibrotic lens capsule. The inferior haptic was tied with sclera. Hoffman's pocket was sealed with fibrin glue. Anterior chamber was formed and the main wound was closed. Post-operative period was uneventful and patient gained a vision of 20/20 with a smile on his face again. These 3 surgical videos and sequential clinical photographs demonstrate how the course of a disease can be, but timely and accurate intervention can lead to a favorable outcome. In future, the patient even may be considered for laser vision correction to reduce corneal astigmatism and improve quality of vision. So, the journey is not yet over.